Next, we have Dr. Ganesh Raja from Kallakurichi presenting rural realities, challenges, and strategies for starting a sleep practice.
Yeah, good evening. Actually, the success of conference started from good morning. Even we are seeing more than 50 delegates here attending the conference. So, Shankar, this is the real success for your conference. Just I am going to present about rural realities. From morning to evening, many persons are talking, many legends are talking about how you are doing surgery, how you are precise your surgery, all the things we got up. But the start is you do the surgery. Then only all the things will happen. Okay? How you are going to the surgery? You will take it vice versa. This is a rural challenge, and also those who are starting the sleep surgery as a new, just take this lesson. This is not a presentation. This is my personal experience, what I have faced in the rural setups. So first, this is why this topic is matters. Actually, many persons are told from morning itself, sleep disorders are even till a date is underdiagnosed. The rural access is very poor, and OSA burden is increasing, and limited sleep infrastructures outside the cities. So the problem is high disease burden, low awareness, and limited access. So this is the magnitude. Actually, what we are seeing is the tip of iceberg only. There is lot of things under the sea. This is actually the data from the city side. Just think about the rural setup. So what is the ground reality in rural India? Actually, the rural areas, what happens in the real practice? Many persons are in the rural setup thinking that the snoring is normal. கொரட்டையா அது ஒன்றும் பிரச்சனை இல்லைங்க. ஸ்லீப் ப்ராப்ளமுக்கு டாக்டர்கிட்ட போகணுமா? அது தூக்கத்தில் வர்றதெல்லாம் டாக்டர் எப்படி சரி பண்ண போகிறாரு? அடுத்தது நான் டயர்டாக தூங்கினா ஏஜ் ஆனால் கொரட்டெல்லாம் வரதானே செய்யும். இதுதான் காமனாக ரூரலில் யோசிக்கிறது. பட் த ரியாலிட்டி இஸ் தே ஆர் ப்ரெசென்டிங் அஸ் லேட் and they are not having awareness. It's a poor awareness, and the major problem is financial hesitations. Yeah, exactly. Even a patient from the rural area want to see a ENT physician or ENT surgeon. Minimum the cost is around 850 to 900 in the city setup. So the problem is main in the financial hesitation, then travel barriers. So if you want a good sleep lab or good sleep surgeon to have a setup and to meet the person, at least travel 200 to 250 kilometers away from the area. So why sleep practices fails in rural areas? Actually, what are the barriers? First of all, it is the awareness. So the low patient awareness, then the infrastructure. This is our side. There is no sleep lab. Then the cost sensitivity. Then the workforce, lack of trained sleep technician, teams, all the things. So the ENT perspective, why ENT specialists are uniquely positioned? The patients are already coming for snoring, nasal block, and mouth breathing. The patient is having tonsil or adenoid, even the sleep disturbance. So the soul is ENT OPD is often the first sleep clinic. So the patient having snoring, the patient is coming to the ENT OPD first. So this is a missed opportunity. Usually, if the patients are 100 in count as a snoring, the 70% are having high risk, 20 come to the sleep study, and 5 only getting treated. This is a huge diagnostic gap is there. So what are the challenges? First is awareness. The patient thinking that snoring is normal. First of all, you should break the point. The patient is thinking that snoring is normal. Then doctors, we are not having the sleep lab, sleep practice, sleep awareness, sleep knowledge, sleep practice knowledge. The under screening is common. So whatever the patient is coming, ask one more extra question: do you have snoring or not? Next, the challenge is our side. This is the infrastructure constraints. There is no polysomnography. Actually, there are 3 or 4 types of 4 levels of polysomnography. The level 1 polysomnography costs around 25 to 26 lakhs. So many ENT surgeons are not having the setup, and there is no sleep technician. It is a costly setup. The maintenance, the burden is there. So many persons are asking, do we need full sleep lab to start for the practice? So not at all. We will see one by one. So what are the strategy? Start small. Don't expect a full setup sleep lab. Build a snoring clinic rather than a snoring center. Instead of sleep center, start with a snoring clinic. Start a workflow with the patient is coming with the snoring. Just have a screening. Screening costs nothing. So then risk stratification, then go for the sleep study, then treatment, whether it is CPAP or lifestyle modification, whatever it is. Whatever it is, if you don't have any setup, start with snoring clinic. So strategy 2, what are the clinical screening? So you are not having any blah blah equipments like sleep labs, all the things. So use the questionnaire, standard questionnaires like stop bank questionnaire, Epworth sleepiness scale. So categorize the patient as low, intermediate or high. The screening costs nothing. Strategy 3, actually this is the message I want to tell. What are the points you can get it from your juniors. This is the point what Shankar is telling to you. Even though you are doing surgeries, all the things, precise your knowledge. If you are not able to start a full-time sleep lab, use the home sleep test. So we got it and we are using nowadays. This is a game changer for rural India. It is affordable, home-friendly, better acceptance and scalable. The fees we will fix. Either it is 2,000, 3,000 or 4,000, whatever it is. So this is a strategy 4. Have a multidisciplinary teamwork. So this is the referral partners. This is also vice versa. The physician will refer to you and you will refer the patient to the physician for fitness, all the things. Have a rapport with the physician, cardiologist, diabetologist, pulmonologist and anesthetist. Always have a high referral triggers. There is a hypertension patient, obesity, diabetic and stroke history. So then many persons are telling that this is the first line of management, CPAP. So the main barriers what we are faced is cost, then fear, then stigma, then the mask discomfort, poor follow-up. So is the surgery is a better option for selected patient? Exactly, surgery is the better option in rural India. So our role of sleep surgery, where ENT surgery fits. Start with the nasal obstruction clearance. If the patient is having bilateral turbinate hypertrophy, just clear it. If the patient is having deviated nasal sub, just clear the deviated nasal sub. So this is tonsil hypertrophy and palatal collapse. Then go for the multi-level obstruction. Always have special mention about the sleep surgeries like UPPP, nasal surgery. Patient selection is important. Surgery is not for everyone, but transformative for selected patients. So this is a practical rural model. How to start a sleep practice in 3 levels. So start screening in the OPD, just categorize the patient and do whatever the treatment. Whatever the treatment, it is CPAP or something else. If you want to do the surgery, do, no problem. So don't expect full setup. So the lessons from the rural experience, what we learnt, awareness takes time. Actually, I advise have a ENT practice along with the snoring practice in the initial days. So we are not built for the only clinic of the snoring. So awareness takes time. Trust build the practice. Outcome drive referrals. This is the most important. The patient is going and telling that I am having the snoring and I got relieved from the treatment of so and so doctor. This is called outcomes drive referrals. The word of mouth matters. The patient telling this is the best communication in the world and best advertisement in the world. Word of mouth matters. Then start simple. So start simple with the snoring clinic. Consistency builds sleep practice. So how I tackle OSA? These are the things. Actually, first one patient is how I tackle OSA, my stepwise approach. The first point is if you want to practice OSA clinic or OSA surgery, have a good mentor. And at least you have a good mentor and at least you have seen a patient or observed a case during your PG period. This is my boss, Professor Anthony told, if you want to be a good OSA surgeon, try to do a good normal tonsillectomy. What is this? Good normal tonsillectomy. If you master with the normal tonsillectomy without any anterepillar injury or post-epillar injury or pharyngeal injury, you will do OSA surgery very neat manner. Don't bother about it. So what I did is, I evaluate the snoring video which is captured by the patient attenders. I see that and I informed to the patient about the surgery option and what are the pros and cons. Then I will go for the surgery. Initially, I screened with the stop bank score and do some CTs like CT PNS and CT neck, and I started with the uvulopalato-pharyngoplasty. This is a radical surgery. So I started with this. I don't have any coablator, I don't have any radio frequency, nothing else with us. What we are having is bipolar and monopolar. Just use the bipolar and monopolar technique. I did the tonsillectomy, it's a perfect matter. As already Sir told, if you master with the normal tonsillectomy, you will do the OSS surgery very perfect. So we will do the normal tonsillectomy in the normal manner. Then we will excise the tissue using bipolar and monopolar and suture it. This is my first case and done well. The results are so good. The patient is 28 years male Ilayaraja, having working in the abroad as a car driver. As a car driver, the patient history is during my driving I slept. This is the problem. Actually the surgery went on well. Then I taken up a surgery of retrognathia with the OSA and treated well. That also come very well. Even though we didn't any sleep study or DICE. So this is the first way. Then after I am doing all this surgery, my junior Dr. Shankar told that precise your techniques and use all the things. So we introduced the home-based sleep test. It is like 1 lakh cost only. So we bought that. Then we precised with our bosses and all the techniques, do the selective palatal surgery like zetaplasty, and we introduced the coablation. Don't worry, the coablation machine is around 30 lakhs. Don't worry about that. Nowadays they are giving the coablation machine if you are buying a wand itself, nothing else. Wand is cost around 12,000. So if you buy the wand, we will use it for at least 3 cases. So the machine is coming as a free of cost. They are giving the machine. So master your technique with the coablation also. Then we went for DICE technique. So we got a machine from the innovative technologies. It's cost around 3 lakhs. Then we are doing DICE. Then the site specific airway evaluation. Nowadays we are doing barbed suspension pharyngoplasty also. Almost around 5 cases we did. In future, this is actually level 1. In future we are having the aim to have a level 1 sleep lab and Shakti sir told DICE polygraphy with the BIS monitor. So this is a comprehensive evidence-based sleep medicine. This is the way of what we have learnt and what I did all the surgeries stepwise manner. So whatever it is, if you know the technique, just apply the technique in whatever the way. This is the future of rural sleep medicine, where we are heading. We are expecting the portable diagnostics, tele-sleep medicine, AI screening, insurance integration. This is most important. Rural sleep centers, the city centers and the big dons of sleep medicine will try to have a mini clinics or sleep centers in the rural part also. So the take-home message is rural OS is always underdiagnosed. Do not wait for perfect setup. Start with a snoring clinic. Screen aggressively. Screen costs nothing. Portable studies always work. ENT can lead rural sleep medicine. So actually, thank you. Waiting for the Thuyilcon 3.0. I say 3 days program. Thank you.
Congratulations, sir. Starting sleep surgeries in Kallakurichi.
Thank you, bro.
And cochlear implant also. Great presentation, sir. Take home message for me too. Yeah. Starting clinic in Atur.
Actually, we did 25 surgeries from 2024 to 26. Out of 25, yeah, OSA surgeries. Out of 25, 23 are doing good. So don't bother about it. Start your practice.
Super, sir.
Thank you.
Thank you, doctor.